All right, let's talk about thoracic trauma. And the first, I guess, let's go over a little anatomy. So we know that the thoracic cage is just below the clavicles or just below the glottic opening. And as it gets down, we have the clavicles and intercostal muscles. We have the hypochondral margins that attaches on the backside to the vertebral column. Within the thoracic cage, we have the pulmonary organs, we have the great vessels, we have the aorta. As it comes down from the oral cavity shares the same space into the trachea and esophagus. But we're looking at the trachea going down and bifurcating, and the carina and making the right and left mainstem bronchus. And we have 3 lobes on the right with 2 lobes on the left, and an opening on the left side for our myocardium. So a short and brief review of the thoracic cage, thoracic cavity, and the structures that lie within there. Now, as far as trauma goes, externally we have a lot of injuries to the chest wall. These are permanently blocked by your upper extremities, as in if there's a frontal assault. Now, in the posterior assault, then we have the larger scapular bones, the larger vertebral column where we have the spinous processes, and it sort of protects us a lot more completely and more thoroughly than it does from the anterior approach. As the anterior approach, the hypochondral margins kind of ride up, they meet into the xiphoid or the sternal area, or substernal, or not substernal, hyposternal area. And so when we look at chest wall injuries, we're looking at injuries to the intercostal muscles, the costals, which are the ribs, the intercostal, which are the muscles, and maybe those attachments that happen up. If you have a rib fracture, more than likely the rib fracture based on compression happens where? Now, there are 1 or 3 sites that this could happen. The first site would be probably along the sternal border. Second would be on the vertebral border. And the last one would be on the angle of the rib. Now, if we think about it, and if you compress the rib, as it is sort of more of a U shape or a wishbone, if you pull apart, it's in the middle of that rib, or that angle of the rib, where a lot of rib fractures occur. Now, that's not entirely all the case all the time. If we have enough direct pressure or direct blunt force trauma, we can have what's called a flail chest segment. Now, flail chest segment is an injury where 2 or more ribs in the same location, in that same general area, are now fractured, and it causes a segment that has this paradoxical movement. And although it's fractured, we're not exactly sure what's happening to the blood vessels that lie beneath each vertebrae, beneath each costum or costal or rib, or whether or not it's actually damaged any of the pulmonary parenchyma or organ. So a flail chest segment should be stabilized. We're looking at some kind of, if it's not open, so we want to try to place some kind of bulky dressing that stabilizes the chest wall, so we lessen the paradoxical motion, so it allows more air to be exchanged. Now, again, because of its blunt force trauma, and it's caused that severe energy and mechanism to cause a fracture of a breakage in the ribs. This is a breakage across the rib where it's broken into 2 parts. So now it's a floating segment. Enough of a floating segment can cause pulmonary contusions, pulmonary lacerations, as well as a pneumo or a pneumothorax. So we need to think about listening to lung sounds and differentiating between whether or not the air is trapped or whether you can see some late signs where we have tracheal deviation, JVD, hypotension, and subcutaneous emphysema. So just based on the mechanism of injury, let's continue on and let's move on to more chest wall injuries. So we can have costal contusions where we just have external injury to that area and nothing internal. But remember, there still could be some pulmonary contusions, pulmonary laceration, pulmonary pneumothorax or hemopneumo. So this is where ribs are bruised up, intercostal margins are bruised up, and that causes some splintings. Now, when they splint to breathe, they're not taking adequate breaths. And when we have inadequate breaths to aerate the lungs and cause those lungs to expand, what we have is called decreased lung expansion. It causes those alveoli to shrink and collapse. This is not pneumothorax. It's the alveoli that are collapsing. And when the alveoli collapse and that lung tissue collapses, it's called, and that atelectasis will decrease the air exchange. And quite frankly, this is what happens post-operatively, that they develop infections and pneumonia that goes on because they're not getting a lot of air in. So we ask them to use an incentive spirometry. Now let's move on to pulmonary injury. We mentioned enough significant injury that can cause pulmonary contusions, pulmonary lacerations, and pneumothorax and hemothorax. So pulmonary contusion destroys or damages the lung tissue. This may damage the actual vital functioning parts of the lung tissue, the alveoli and the capillary bed, the ability for lung tissue to exchange oxygen. So we may have a decreased oxygen exchange, causing the end-tidal CO2 on your EKG, your monitors. End-tidal CO2 to be displaced, and also may cause SpO2 to be displaced, and they probably would be a lot more tachypneic. If there was let's move on. If there was more of a severe injury where it's more than just a small pneumothorax, but pneumothorax that's enlarging, we may have a distance or diminished lung sounds on that particular side. May have plus or minus subcutaneous emphysema, JVD, tracheal shift away, so it's pushing away. As the pressure builds up on one side, it pushes towards the unaffected side. and because it's pushing everything away, it may crimp or crimp the aorta, and it may also compress on the myocardium and cause the myocardium not to eject enough, and so that might cause hypotension. Now, again, pulmonary contusion is just as serious as a tension pneumothorax. It's just as serious as a hemopneumothorax. So we just need to be aware of what's going on. Now, hemothorax is where the blood is leaking into the potential space between the parietal pleura and the visceral pleura. And this may be because the lung is injured or bleeding or lacerated. And so bleeding builds up in that potential space, and that potential space of fluid will tend to flow with gravity and extend downwards, causing decreased blood flow, decreased air movement. Anytime we decrease the air movement into the chest, we decrease the chance of oxygenation and exchange of carbon dioxide and oxygen. Now, the rest of the cardiovascular system lies also within there. The myocardium, which is quite important, and the great vessels, which is the aorta and the superior and inferior vena cava.